Okay, good afternoon, everyone. My name is Nick Bima. I'm with Bard Peripheral Vascular. I'd like to welcome everyone to the VascuTrack live case/lunch. I'd like to take this opportunity to quickly introduce our panel, not that they need much of an introduction. First, Dr. Walker will be delivering the didactic portion. Dr. Walker is the director and founder of the Cardiovascular Institute of the South and also a professor of medicine at Tulane University. Of course, Dr. Mustafa, who is the course director here at AMP and the man responsible for this fantastic meeting. Dr. Davis out of St. John, Detroit, and Dr. Bunch unfortunately could not make it today. And then last, Dr. Metzger, who will be delivering our live case out of Wellmont CBA Heart Institute in Kingsport, Tennessee. So I think that's enough talking from me. I'm going to hand it over to the professionals. Dr. Walker, if you could take it away. Thank you.
Sure. Hey, Chris, we see you up here. How you doing?
Fantastic, Craig. Welcome. Good to hear your voice. I heard your last lecture, a Southern man speaking quickly. You did a great job with it.
Hard for a Southerner to speak fast.
It really is, and I've adopted that. So welcome to Kingsport, Tennessee. Jihad, we're thrilled to be part of your meeting. It's gone fantastically by everything we've heard here, and thanks for having us. And thanks to Bard for supporting this symposium. We've got a great case and we could use your help. Before I start, I want to briefly introduce our team, and then I want to show you the case, and then I think that we should have some lively panel discussion on what we're going to do, and then we'll just see if you agree with what we've decided we're going to do. So without further ado, to my right, Jimmy Browder. STEMI call last night, and you can't tell by looking at her, smart and beautiful as ever. Behind us, Mike Hubbard, providing nursing expertise, and Sarah Allen will be, you'll see, we're going to press her into service in multiple roles, including fluoroscopy, to help a short man out during this case. So welcome. Let's go to our slides and show you our case. Next slide, please. This gentleman is a fantastic 72-year-old fellow with very long-standing diabetes, hypertension, the former risk factors, and importantly, renal insufficiency. Importantly, in addition to his obstructive sleep apnea, he is very tall, much taller than this doctor. He is 6'4", okay? He's developed non-healing ulcer on the second toe, more than his right great toe. His ABIs were completely non-compressible in both the anterior and posterior tibial arteries, and he had a toe pressure of 0.17. His duplex showed an occluded right posterior tibial artery and extremely high-grade disease throughout the mid and distal anterior tibial artery, providing the supply to his affected toe. And also, as you'll see, he has important venous insufficiency after bypass surgery in the past, but he does not have any DVT. Next slide, please. So on prior angiograms, this just shows you that there was no aorta-iliac disease. This was done from the left contralateral approach, and you can see he's got a big SFA with no significant disease there. Next slide, please. These are some slides from before, again, contralateral approach, and what you'll see is the posterior tibial is going to occlude distally, and there is going to be diffuse calcific disease throughout the anterior tibial artery. You can see on the still frame on the right side of the screen how the PT is out, kind of obliterative distal occlusion, and then the anterior tibial diffusely disease. And the next picture, please. And you can see that when you look at the foot, you can get a sense of the venous insufficiency there. And you can see that you do have reconstruction through the arch from the anterior tibial artery and some collaterals to the posterior tibial artery. So next slide, please. All right. So if you'll come live, please. So the question, Craig and Tom and everybody, sorry, Frank's not there, is we've got a 6'4" gentleman with anterior tibial artery disease that's heavily calcified. The PT is out. He's got renal insufficiency and a toe ulcer. First, let's start with access, and then what do you think we should do with this anterior tibial artery?
Let me go first, and then we'll certainly go through the whole panel. This would be a case that I would do antegrade access to start with. But I would be prepared, if need be, to try a retrograde access. Second thing that I would do is I would use CO2, not contrast. CO2 is very useful in this situation if a patient can hold still. And I am more commonly finding myself using CO2 because so many of these patients or renally impaired. I would then probably follow this with some debulking, the device of choice that you wish, and I would use a long vascular tract balloon. I think that being able to dilate this very long segment disease makes a lot of sense. How about Jihad or Tom?
You know, Chris, this is Jihad. Definitely actually echo Dr. Walker's comments. Definitely we'll go integrate for sure, and then try to cross in integrate fashion. And I appreciate the lateral view that you did of the foot, which indicate that there's a pedal loop intact. And most likely, once you fix the AT, it's going to be looking very well. In terms of therapy of this tandem lesion, again, I echo Dr. Walker's comment that possible some form of debulking followed with vascular tract balloon. The question is here, Chris, what size balloon will you use?
Yeah.
We'll pick on that later.
I remember your comments from earlier. Yeah, absolutely. I know who's on the panel there. All right. And then any other thoughts there?
Chris, I have a question. Do you have CO2 there available?
We do have it. You know, as we're going to talk about antegrade, it's going to be antegrade, and I'll show the pictures. We're not using CO2, although I think it's a great idea. We've hydrated him aggressively before and after. We're using Visipake, and we're going to use his little dye, and it's certainly mixed, probably 1/3 dye to 2/3 saline. And again, even Jimmy post-STEMI is a master at doing that. Yeah, and we're going to use just focused road maps that we're going to use, both smart maps and road maps, as you'll see. So we'll get by with a little dye, but we're not using CO2.
I think the antegrade approach is a good idea.
But it's a great comment.
Especially because you can put a longer sheath down there all the way down to the popliteal, really, and then limit your dye being washed out there. And I think we get better focused pictures if you're going to do that. So I would agree with the rest of everyone else on the panel, though. I think some form of atherectomy and long balloon angioplasty.
Yeah, all very important. You know, Chris, in today's world, though, now there are sterile, very small CO2 canisters that are available. Unlike the old days with the 400-pound bottles, it's less expensive than contrast. It's not more, it's less. You can use it on these people, and it's really been transformative in my practice. I would say that we've been able to treat a whole bunch of people we couldn't in the past. You know, sometimes in just trying to conserve contrast, you have a patient with no reflow or other things. It's very difficult to follow what's happening, and CO2 has totally changed that.
So, Chris, one point I want to add about that lesion. It's long tandem lesions, and we've seen this in the past where you try to take a wire down, and then suddenly, you know, the wire goes subintimal, and you go from tandem lesions into a total occlusion. I'm sure you've thought of that. Is there any specific wire you have in mind that will help you navigate through with that added risk?
So great question, Jihad. So I'm going to show you what we've done to this point. And you know the good thing as a live case operator who respects his panel, I love it when brilliant folks like you have suggested what we've done. That makes it a whole lot better. I feel better about what we've thought. So Dan, if you'll go to our images here. So we have become a fan of using vascular ultrasound to help us. And so what we did is we got antegrade access. And as sometimes happens, and it always happens in a live case, the wire went into the profunda. So our trick for that is to leave a stiff wire in the profunda, do a road map, and then take a glide wire into the SFA, which is what we did here in an ipsilateral view. We then take a quick cross catheter or whatever your favorite transfer catheter and take a supercore supportive wire into the anterior tibial. And then you can see here, Tom, to your point, which I agree with completely, this is a 55-centimeter Ansel sheath down as far as we can go in this 6'4" guy, okay? That lets us get close to the action, all right? Now I'm going to show you pictures from today from that Ansel sheath, all right? So we're going to go through those. Some disease, but not terrible. And then, as you said, Jihad, look at all these tandem, almost subtotal recanalized, almost, and some really tight lesions. And the last thing I want to do is go subintimal on any of them, because that hurts our debulking strategies. And you can see there's a lot of these subtotal occlusions that are heavily calcified, as we know. And you can see how the anterior tibial goes slowly, but does reconstitute and goes all the way down there. And then I'm going to show you a picture of the foot. And you've got this arch that reconstitutes. Okay? All right, now, in answer to your question, what we did, the wire that we chose to use, we used an 014 exchange catheter. We used a quick cross, and we used a command 014 wire. We like the nitinol reshapeable tip. And so here on a road map, you can see we're just going very slowly, staying within the lumen at all costs, okay? And then finally, using a road map, we're able to get down here closer. And in fact, you'll see we're actually able to wire all the way around back up into the posterior tibial artery with that command wire, and we really like that steerability there, okay? So we've got our wire far south, and in fact, if we had a heel ulcer, we would even think about going up there and doing something retrograde up there, but we don't need to do that. Remember that we're a toe, this is an anterior tibial, and we're just, with a renal insufficiency, we're going to do what we came for. All right, now, so what we did there was and that's nothing there. So what we did was we took our quick cross catheter down, and we exchanged. We thought that the best device for this to prepare the lesion was going to be an orbital atherectomy with the CSI device, okay? Now, what we're going to do is be conservative, because there's a lot of debris, there's a lot of plaque down there, and what we don't want to do is send microemboli proximally into that distal type disease and close it off, recognizing the importance of this vessel. So we're going to go with a 125 microcrown, okay, and then go down there and try to create a channel and modify the plaque, and then use the panel suggestion of using a long vascutract balloon after lesion preparation. Does that sound like a good plan to everybody?
Yes.
That sounds great.
Now, so what we were going to do, I was going to ask, and I think I've answered the question, what we had decided, and again, we appreciate everybody's comments there, was that, the one question is, did we need to take a 1.5 balloon and treat some of the outflow way downstream so that we'd have less chance of clogging it off? And if we met any resistance with the quick cross catheter, that's what we were going to do. We got that through fairly smoothly, so we're going to go and treat from proximal to distal at low rotational speeds, okay, to limit the amount of, hopefully, distal embolization. And then we're going to treat it at moderate speed on the way back. And the beauty of this device is, as everybody knows, it's equally good in the forward and reverse directions. Now, one other note, you can notice maybe that the patient is backwards on their table. I wish this was his left leg. It would make it a little easier. It hits his right leg. And then I wish I was a little taller. I'm not. And I also have a C7 radiculopathy here. So Sarah's going to help me. I'm going to stand on a stool, and I'll make no bones about it here. And Jimmy's going to help me here. So, Flora, please.
Dr. Metzger, this is Fadi Saab from Metro. I want to ask the panel why you're advancing the device, specifically starting with Jihad. This case at Metro, I know what you would do, but I'm curious to see what the panel would think about using ultrasound prior to intervention and post-intervention, especially in a patient with renal insufficiency.
Okay, you got it? You okay?
Well, Tom Davis doesn't know how to use ultrasound. That's a problem. Fadi, that's a good point. The utilization of ultrasound in renal failure patients has been extremely helpful in our institution. In fact, it lowered the contrast utilization almost by 70% in these cases.
Yeah, for me at my institution, it's very difficult to get an echo tech in there. You guys stock that routinely, and I think it's a great idea. We just don't have them, readily available. CO2 lets you do that imaging very nicely as well. And I've got to,
hey guys,
I keep harping on that, but it really is a helpful tool.
I wanted to ask Dr. Diaz, actually. Diaz, can you come up here, please? Dr. Diaz has done very nice work with CO2 in the tibia. And he has got some good input on that. We'll just hear his comments on that.
I kill you. All right, so nice.